So when we talk about the shoulder, we're not just talking about the glenohumeral joint, right? We're talking about this complex of the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint. All four articulations have to work together to permit optimal function. So the glenohumeral joint is a multiaxial ball and socket. Head of the humerus 2 to 3 times larger than the glenoid fossa, so only 25 to 30% of the humeral head is in contact with the glenoid fossa during range of motion. So it's inherently unstable joint. The glenoid labrum increases the concavity of the fossa and helps with stability. The joint capsule, the capsular ligaments, all that stuff, and extensive muscular support help to keep the glenohumeral joint stable. Okay? The acromioclavicular joint, it's just a plain joint with an articular disc that helps to increase congruency. Relies on the joint capsule and ligament to support for it to stay held together. One of the first joints in the body to suffer from degenerative changes secondary to osteoarthritis for whatever reason. So if we look at glenohumeral joint and acromioclavicular joint, and here we have the coracoacromial ligament, coracoclavicular ligaments. All these things play a part in certain aspects of shoulder dysfunction that we're going to talk about. So the sternoclavicular joint is the only true articulation attaching the shoulder complex to the axial skeleton. The axial skeleton, your spine, right, your rib cage, pelvis attaches your lower extremities to the axial skeleton. The only point in which your upper extremity, your entire upper extremity, is attached to the axial skeleton is at the sternoclavicular joint, right? The clavicle attaches to the acromion, which is part of the scapula. The humerus attaches to the scapula, and there you go, right? Then you have the rest of the arm. So the sternoclavicular joint is inherently unstable by virtue of its anatomy. Only about half of the clavicular head articulates with the sternum, but it has a very extensive ligamentous support. I've never seen a sternoclavicular dislocation, although I'm sure they happen. You're much more likely to fracture your clavicle than to dislocate your sternoclavicular joint. So this is what it looks like. This is the joint capsule. You have these ligaments here. You have a costoclavicular ligament from the first rib attaching to the clavicle, keeping it held down. You have an intraclavicular ligament holding each clavicle to each other, actually, running over the manubrium of the sternum. The scapulothoracic joint is a false joint, right? Because there's nothing that actually articulates, right? The scapula just sits on top of the ribs, and it's bound to the thorax via muscular and fascial support. So this is what the scapula would look like if we didn't peel away some of the muscles. You have the trapezius that runs over it. You have the lats that kind of overlap underneath there. You have the rhomboids, levator scapulae, and then there's all your rotator cuff muscles and teres major. So the scapula is essentially floats over the rib cage, right? In terms of pathology, be aware of age-related changes when you're working with someone who has a history of shoulder problems. Generally, instability you see more in clients under 30 years old. Dislocations, less than 20 and greater than 50. Why do you think that is? Dislocations, younger than 20 and older than 50. Those are the populations where you're most likely going to have falls, right? Little kids running around playing sports fall, dislocate their shoulder. Older people with bad balance fall and dislocate their shoulder, right? Everybody in between, you don't see dislocations quite as often. But the problem is once you have a dislocation and you lose some of that stability from the capsule or the labrum, whatever is injured, they become repeat offenders, okay? So it's something that happens to them repeatedly, and sometimes it requires surgery to stabilize the joint. Rotator cuff pathology, usually 40 years old and up, but it can happen, really at any age. So how you injure the AC joint, you fall on the shoulder essentially, right? Injury to the AC joint is a separated shoulder, if you guys have heard that term before. It's a stretch or a tear of the AC ligaments. Grade 1 and 2 is just a mild separation. It just varies in degree. Grade 3 will have a significant prominence of the distal clavicle. That's where they're no longer articulating, okay? The clavicle and the acromion are separated. So that's what a grade 3 would look like. Here's your acromion. There's your clavicle. So shoulder instability compromises comfort and function. So multi-directional instability, they're not surgical cases. They need strengthening. Those are the people who can kind of like pop their shoulders out. You have like friends like that when you were a kid? That's multi-directional instability. A subluxation is when it pops out and spontaneously reduces. And then a dislocation is a complete separation of the articular surfaces without spontaneous reduction. So this guy has a dislocated shoulder. He's got to go get that relocated, right? That's not popping back in on its own. So it's not so much that you're concerned about this initial injury, but it's the after effects of it, right? If they've lost stability in the joint because of the injuries they get secondary to that. So when you have somebody with shoulder instability, you have to look at the onset. Is it traumatic or is it something related to overuse? Was it a dislocation or a subluxation? Subluxation is a much better case scenario. Frequency, once you have a dislocation, recurrence rate is about 90%. So once it happens once, it's probably going to happen again. Volition, right, is a volitional. 95% of the time it's an anterior dislocation. So the humeral head will dislocate into like that subpectoral groove, that area there. So the injuries that are associated with that, most significant to us, I think, are labral tears. So the different types of tears depending on the region of the labrum that's injured. So on MRI, this doesn't look like much, but that's actually, so this is the labrum, that white area, and those fibers there indicate a tear in the labrum. Okay? Now, again, this is the type of thing, you could have clients who are walking around with labral tears in their hips or their shoulders, and it doesn't cause them any problems, so you don't really worry about it. But if it's the type of thing that's really symptomatic for them and they can't really deal with it, it's affecting their everyday life, they can go have that surgically repaired. So rotator cuff pathologies, okay? Rotator cuff is responsible for the dynamic stability of the glenohumeral joint. It's difficult to distinguish from other sources of shoulder pain. So when I see a diagnosis of rotator cuff tendonitis or subacromial bursitis, to me it's just a kind of guess on the doctor's part, right? They spend a couple seconds with the patient, they see they have shoulder pain, they say impingement or tendonitis or bursitis. Very similar presentation. Patients can often be asymptomatic. You can have a small tear in your rotator cuff and it doesn't really change anything you do. It doesn't change what you do with your clients all that much. But if they are someone that's having problems, right? If you see weakness in the supraspinatus, weakness of external rotation, and they have a positive impingement test, there's a 98% chance that they have a rotator cuff tear. So if we look at just the musculature, this is the anterior part of the scapula, so that's your subscapularis. This isn't infraspinatus. I don't know why they have that there, but supraspinatus, infraspinatus, and teres minor along the back there. So incidence of rotator cuff tears, 20% in individuals over age 50, 50% of dominant shoulders by age 70, 80% by age 80. So what does that tell you about rotator cuff tears? You guys who work with older clients, they probably have some pathology in their rotator cuff, right? The tendons are not really well vascularized. Bony changes around the shoulder joint can damage them over time, and they're not going to really heal themselves, okay? So I did a consult with a guy the other night in his mid-70s who flared up his shoulder. He's had problems off and on playing golf. He hit the ground, and that impact has given him shoulder pain for the last couple of weeks. And he said, oh, the doctor thinks I have a rotator cuff tear. I said, well, you probably do, just because you're 76 years old. So, the likelihood is that you do. But that doesn't change the approach in terms of how I go about treating him. He's not a candidate for surgery, in my opinion, at 76 years old and sedentary. So this is the supraspinatus here, humeral head. This is the glenoid. That's the acromion. This is what a tear in the supraspinatus would look like, right? And again, this is repetitive overuse. If you have some sort of bony buildup or you just have really poor scapular mechanics that you keep impinging this tendon here, eventually you're going to get some sort of tear. That's why the incidence goes up so much over time. Signs and symptoms of rotator cuff pathology. Number one complaint when I know someone has a serious injury to the rotator cuff is they tell me that they really can't sleep because anytime they roll on that shoulder, it's painful, wakes them up at night. That's an indicator to me that it's something that's more serious. So if you have a client who has a little bit of shoulder pain and then they start telling you it's affecting their sleep, you know, go send them out to somebody. Obviously, weakness in the musculature, tenderness to palpation at the greater tuberosity, right? That's a lot of times an indication of a possible long head of the biceps injury, or maybe injury to the superior anterior part of the labrum. Painful arc. So when you have them abduct, right, they'll have pain through part of the range of motion that'll kind of go away. And a drop arm test is where you're kind of holding their arm out supported, and then you just take the support away. If they can't really stabilize all that well, it's probable that they could have some sort of rotator cuff injury. So where do rotator cuff injuries come from is subacromial impingement, which is an encroachment of the cuff on the acromion, the coracoacromial ligament, the coracoid process, or the AC joint. Leads to inflammation, edema, hemorrhage, and possibly total failure. So this ligament right here causes a lot of problems for people if they have poor mechanics. So, you know, the people that we work with, your typical, you know, older client who maybe has been working in front of a computer for the last 20 years, if they have real poor posture, right, and increased thoracic kyphosis, internally rotated glenohumeral joints, and poor mechanics of their scapula, right, they don't really get that upward rotation that we like to see in the press when we have them shrug, you know, they're going to be more likely to develop some sort of impingement over time. That coach that I had mentioned, they released his coracoacromial ligament. They just got rid of it so that he wouldn't have impingement going forward. So there are structural factors. You can have someone who has a malformed acromion. There's no way that you can really know that unless you have some sort of imaging that supports it. So the way I approach things with people is, again, it's about symptoms, right? If they're not having symptoms, you press, you can do snatches, you can do whatever you want with them. It's if they start to have problems that you make some sort of adjustment. Obviously, bone spurs. We'll talk about bursitis a little bit later. In terms of functional stuff, so capsular hyper or hypomobility. Okay, some people are just more loose and flexible than others. Some people are not. Weakness of the scapular stabilizers, right? So if those muscles that support the scapula on the rib cage are not doing a good job of positioning the scapula for movement, that can lead to impingement, right? So this is what different types of acromion look like. This is ideal, type 1. Type 2, we have a little bit of a hook to it, and type 3, that's worst case scenario in terms of decreasing that subacromial space and leading you for increased risk of impingement. So generalized goals of rehab, obviously decrease pain and inflammation. First thing is to reestablish full range of motion, right? After a rotator cuff repair or some type of rotator cuff injury, before you can really load them effectively, they have to have the range of motion, right? Rip, after your shoulder surgeries, you went after your range of motion pretty aggressively and getting that back so you can start doing your presses and stuff again.
Yeah, you can say that.
Yeah, so a lot of times what the general recommendation is for patients is to be in a sling for anywhere from 4 to 6 weeks. Some doctors send people to PT the next day. I've had people one day post-op after a rotator cuff repair in for PT for just really range of motion, passive range of motion, just to get them stretched out so they don't get tight. You guys have heard the term frozen shoulder, right? That's where the capsule itself kind of gets stuck to each other, right? The extra slack in the capsule, and they call it frozen shoulder.